In this video, we demonstrate the management of a leaking bleb that had for a while left us stumped as to how to stem the leak. A 77-year-old gentleman presented to us with a visual acuity of 6/9 in both eyes, with IOP of 19 and 20 in the right and left eye with maximum medical therapy. He had undergone peripheral iridotomies 3 years ago and gonioscopy showed prior signs of occlusion. The disc showed a CD ratio of 0.6 in the right eye and 0.9 in the left eye. Visual fields were normal in the right eye and showed advanced damage in the left eye. In view of advanced damage and poor control on medication, he was scheduled for a trabeculectomy with mitomycin C. A limbal-based conjunctival flap was made. Pieces of Wexel sponge soaked in mitomycin C 0.02% were kept over the sclera for a duration of 1.5 minutes. Then a thorough wash was given. A triangular partial thickness scleral flap was raised. Trabecular meshwork block excision and peripheral iridectomy were performed. The scleral flap was closed with a 10-0 nylon suture. The conjunctiva was closed with a continuous purse string suture. Watertight closure was ensured. On the first day post-surgery, his intraocular pressure was 10 mm of mercury, bleb was diffuse, appeared over-filtering and Siedel's test was negative. On the third post-operative day, he presented to us with a drop in the vision. His visual acuity had dropped to 6/60 and his IOP was 6 mm of mercury. The anterior chamber was shallower, with 360 degrees iridocorneal touch and choroidals in the center. A small area of wound gape was noticed and Siedel's test was positive from the stitch line, confirming a bleb leak. The bleb was resutured on the same day. A single 8-0 vicryl suture was placed and after ensuring watertight closure, the eye was patched. The patient was examined the next morning only to find a leak again. There was a larger wound gape and the sutures were not holding. Anterior chamber was very shallow with choroidals reaching up to the center. The question was what to do next. It was akin to the little boy who had to decide whether to plug the leak in the dam with his thumb. A decision had to be taken immediately. Since we suspected the problem in healing was due to the use of an antifibrotic agent, we knew that suturing alone is not going to be of much help. We decided to take up the patient for AC reformation and bleb reconstruction with an amniotic membrane graft. The leaky bleb was examined and the points where the leak was present were noted. There were 2 areas of leak with a significant gape. The edges of the wound were opposed and 2 more 8-0 vicryl sutures were taken. At this step, we checked for any leak from the wound and the attempt was made to ensure complete watertight closure. We decided to use a multi-layered amniotic membrane graft to enhance healing and support it with an overlay monolayered amniotic membrane graft. 2 amniotic membrane grafts were fashioned. The first was a multi-layered graft which was fashioned by folding the graft in 4 folds with the epithelial side inwards, so that the stromal side can help in healing of the wound. The second amniotic membrane graft was a monolayered graft which was prepared and kept aside. The area was thoroughly dried with a Wexel sponge before application of the glue. The 2 components of the glue were applied in equal measures and the graft was positioned. We ensured that it had dried and was in place. The area over the first graft was thoroughly dried. Fibrin glue was again applied and the monolayered graft was then placed over the first graft. We ensured that the epithelial side of the monolayered graft is facing upwards so as to provide a scaffold for healing towards the stromal side and also prevent it from sticking to the lid. We ensured that the graft extended well beyond the margins of the bleb. Once the glue had dried, the AMT was sutured and the graft was anchored at 4 corners with 8 ovicral sutures. We ensured that the graft was well anchored and in place. The patient was seen the next day, and once his patch was opened, the graft was found to be in place, although the superior half of the graft had displaced downwards. The area of leak and the wound gape could be seen exposed. That means the graft was not covering the same well. We realized it would worsen with the movements of the eyelids, and leaving his eye open was not an option. We decided to reposition the graft on slit lamp with the help of a Wexel sponge. The area was dried and glue was applied and the graft was replaced. We patched the eye after applying an antibiotic steroid ointment and atropine. The patch was opened after 24 hours and the graft was in place. The bleb was formed under the graft and there was no leak. Anterior chamber was formed but shallow. Hence, we decided to keep the eye patched with a steroid ointment for another day. Following day, the anterior chamber deepened and the bleb was appearing formed. The choroidals had reduced and were not seen in the center. The patient was advised topical steroids and atropine and kept on close follow-up. At last follow-up, that is 6 weeks post-operatively, his vision was 6/9, intraocular pressure was 11 mm of mercury, the anterior chamber was formed, bleb was diffuse and there was no leak. Thus, a leaky bleb was saved, the patient retained his vision and his pressures were controlled. Bleb leak is one of the most frustrating complications that can occur in trabeculectomies with the use of antifibrotic agents. Hence, one should be cautious with the use of antimitotic agents in elderly patients with thin conjunctivas. Appropriate and timely management of such complications can lead to a good surgical outcome.